did a bachelor's degree in economics from Yale University, and then worked as a financial analyst at Bear Stearns and a business analyst for McKinsey and Company. So much to his wife's chagrin, he decided to go back and become a student again for many, many years, went to medical school, and then completed residency with us in Toronto here, where he was also our chief resident. He then went on to do his glaucoma and advanced anterior segment fellowship at Trillion Health Partners with Dr. Ike Ahmed, and also completed a Master's of Science in Epidemiology, excuse me, at the Harvard School of Public Health. He's now our chair of resident, chair of resident research in the Department of Ophthalmology, and he also sits on the Kensington Research Committee, and he's a regular presenter at both local and international meetings, and has published in numerous publications on both glaucoma and cataract surgery. So welcome, Dr. Schlenker and team.
Thank you, John, for that kind introduction. Really appreciate this opportunity, and hopefully there'll be something for everyone in these two presentations. We have two of our esteemed residents here, both PGY3s, kind of been doing their glaucoma and cornea rotations right now. Yogi just spent a couple months with us at Kensington, Toronto Western. And we're going to start with him. He's going to present an interesting case of a young guy. When you're listening to the case, the patient kind of looks like Yogi. So you can kind of get a sense of what we're up against. So Yogi, why don't you go ahead?
Sure, we'll get this shared here. Excellent. Oh, and I already skipped to the differential. Excellent. Okay, well, good morning, everyone. Everyone can see my slides there well? So I'm going to be, again, my name is Yogesh Patodia. Thank you, Dr. Schlenker, for allowing me to present this presentation on a very interesting case. It's the case of the implantable collamer lens causing glaucoma or an innocent bystander. And today's case mainly is going to be, we don't really have an answer as to the diagnosis or management. With this case, we're really hoping that this presentation will stimulate a little bit of a discussion. And we're hopefully going to be able to see what the audience thinks about what's going on here and what we do next. And I've included the QR code for the evaluation. So if anyone would like to fill that out now, I also have it at the end of my presentation as well. So we'll get right into it. Most people don't know, or most people may not know, but an implantable collamer lens is a phakic IOL. The most common one found in North America is the Star Vision ICL V4. And it's like in the picture, it's a rectangular one-piece plate haptic that sits in the sulcus space. And it corrects typically patients with high myopia, anywhere from -3 to -50 diopters of myopia. And it typically requires at least 3 millimeters of anterior chamber depth. So again, that's the space between the corneal endothelium and the anterior face of the lens. So it kind of fits in that space there. So let's jump right into the case. We've got a 32-year-old gentleman. He's a very healthy guy, high myope. And I want to press upon the fact that he's a very high-functioning gentleman. He's was a prior dental student. Unfortunately, because of his visual issues, had to drop out, became a podiatry student. And, in talking with him in our clinic, he was very, very passionate about his ICL surgery. He told us it was life-changing for him. He wasn't able to tolerate contacts or glasses at the time. And, after he got the ICLs, his quality of life significantly improved. So he was he sold us on them essentially. But let's go over his past medical or past ocular history. The right eye, for the most part, was pretty quiet throughout this entire process, although there were some changes. The main focus today is a lot on the left eye. So I just wanted to go through the time course of everything. In 2013, he had a MAC on retinal detachment with a buckle at the time. He developed a little bit of diplopia a few years later, had a strabismus surgery that was redone in 2016, and the buckle was actually removed. And then in mid-2016, he had the ICLs placed. And then fortunately, in his left eye, again, he developed another MAC on retinal detachment and had a pneumatic retinopexy with gas at that point. And then in 2018 was diagnosed with glaucoma, mainly in the left eye, and was started on Alphagan or brimonidine, and his Tmax was listed as 35. So he presented to the Emerge clinic, and some of the residents may actually know his case if they were at St. Mike's, but they presented to the Emerge clinic with 2 to 3 months of blurred vision, redness, and high pressure that was measured by an optometrist. What actually prompted him to go in to see an optometrist was that he stated, and again, a very attuned gentleman, he stated that he knew when his IOP was elevated, it kind of woke him up at night, or it kind of bothered him throughout the day. And I know sometimes I think sometimes we glaze over that fact, but we took it at face value. So his exam at that point was 20/30 in the right, 20/50 in the left. He had a left RAPD, IOP of 28 in the right and 34 in the left. His slit lamp exam was relatively unremarkable. Dilated fundus exam showed cupped out nerves, the left a little bit worse than the right. Retina was flat. There were stable peripheral changes from the previous 2 retinal detachments. And at that point, he was started on all 4 classes of medication and Diamox. He was urgently sent to our glaucoma service the following week later, where we saw him. And unfortunately, at that point, he was only using the Simbrinza because he couldn't tolerate the Diamox or the Duotrav. Vision remained stable and the pressure improved. More importantly, on the exam for us, the cornea was clear. There was no endopigment. AC showed no cells. And more importantly, there are no transillumination defects in the iris. And arguably one of the most important things to do on a glaucoma exam is the gonioscopic exam, an undilated gonioscopic exam. And so I just wanted to highlight out here the Schaefer angle statuses and what we had for our patient. And as you can see in the right eye, there were mainly some areas that were open with trabecular meshwork. However, in the left eye, it appeared to be mostly occludable. Again, no visible structures in the majority of the quadrants. So again, very suggestive, very, very suspicious in this case. So at this point, we decided, well, we're going to send him home with what's called an eye care home tonometer. And it kind of gives us an idea where we're looking to see if he was going into any intermittent angle closure attacks. And we asked whenever he felt that his pressure got high or he felt that it was high, he used the eye care home tonometer to get a reading. And hopefully give us a little bit of information, but we'll go over that. We also got some anterior segment imaging, a visual field and OCT. I started him on timolol and said, we'll follow you back up in about 6 to 8 weeks. So I wanted to highlight the ends here. It's the right eye's on the left side here, the left eye's over here, and we have the vertical axial and the horizontal axial of the UBMs. Again, our imaging, unfortunately, with this is not the best, but the main thing I wanted to highlight here is that there does appear to be a little bit of anterior vaulting of the IOL that's causing a slight narrowing of the angle. We're unable to really locate where the scleral spur and trabecular meshwork is on these UBMs because again, the resolution is not the best, but it gives us something to work off of and correlate with our gonioscopic exam. Moving forward to the anterior segment OCT, you'd probably look at this and be quite surprised because, looking at this, it looks actually quite open. Again, with the technology that we had available to us, we were only able to get a single horizontal slice. They gave us a nasal to temporal sort of slice through the cornea. And so it was only able to look at areas that were actually quite open in our gonioscopic exam. So again, we take these with face value. Or we take them kind of with a grain of salt. I think the one thing I wanted to highlight out here was just in the left eye, you can see the IOL vaulting here and then changing direction. So the one in the left eye may have been placed a little bit off center, or it may have shifted over time. That might be relating to some of the changes that we're seeing in the left eye. But again, take it with a grain of salt. Moving on, I'd like to talk about the eye care home report. And so this, again, as I said, we see a nice graph here showing the peaks and valleys of his IOP. But when you actually look at the data itself, his mean IOP actually appeared to be pretty stable, in the right eye 17 and the left eye 14, spikes only up to 26 and 21, and a pretty good standard deviation. Now, again, I wanted to impress upon the fact that this was on 2 classes of medications in the right and 3 in the left. So this may have been dulling or muting a little bit of the spikes that we were getting. It's difficult to say, but we weren't about to stop all of his medications and have him try the eye care home report or try the eye care home for a week. So again, something to take just some more data that we can kind of present here. So at this point, Dr. Schlenker, I don't know if you'd like to ask upon someone for the differential, or I can just go through it.
Sure. Why don't I think we saw Ike on here. I was wondering if Maybe Ike and Paul, I wouldn't mind getting some comments just based on what you guys have seen from the imaging. I can tell you too that the gonio was difficult in this gentleman. My first impression when I did gonio was, you know, this is a previous high myope, and I was quite surprised that the angles were shallow at all. I haven't seen a lot of patients with these ICLs. He also had trace pigment or trabecular meshwork, so very difficult to identify landmarks. I can tell you for sure that I did not see any peripheral anterior synechii, which is obviously reassuring, but I felt the gonio was at least as bad as what you saw in the imaging. The anterior segment OCT actually looked reasonably open, at least on the temporal side, and the UBM is a little difficult, but I got a lot more of a closure type feel to what I saw in the UBM. Ike or Paul, you want to make any comments on what you see from the anatomy?
I mean, is that me speaking? Sorry. You know,
Yogi, if you mute yourself and maybe why don't you put up the imaging as Paul's talking?
Sure.
UBM.
You know, I would agree that, you know, when you're looking at the anatomy, one question I have is the undilated pupil. You notice any difference in terms of the size of the undilated pupil between either eye, or do you find that either of the pupils themselves look a little larger than what you might find on an average person of similar age?
I would say no, the pupils look quite normal. There's an RAPD on the left side. So,
Yeah.
you know, maybe a little bit more dilated there when you're shining in the light, but nothing, nothing untoward, and not necessarily signs of UGG per se.
Right. You know, when I look at a picture like this, you know, it's important to look at the difference between the two eyes. So I'm assuming that the refraction and the axial length was the same. So there is, you know, when I'm looking at this and comparing the two eyes, an obvious difference between the anatomy that you're seeing between the two. And that, you know, in terms of my experience in implanting ICLs, both pre-op and post-op, you know, they tend to look the same, unless one thing you would have to consider is there a sizing error in terms of the ICL? You know, when we look at ICLs, we look at both the anterior chamber depth. We also look at the white to white, and so those are important factors in terms of is the ICL sized appropriately? Obviously, if it's too large, it's going to crowd you know, bow forward. It's going to crowd the angle. So that's one metric or one factor that you have to consider. You obviously need to have you know, the preoperative data to look at that, and you can look at the vault as well. So that's another important thing. It's a little difficult to see what the vault is. The vault basically is what's the you know, what's the distance between the anterior lens and the posterior aspect of the ICL. You want that to usually be, you know, the STAR usually likes it to be anywhere between 250 and 750 microns. And so you're looking at, you know, around an average corneal width as a benchmark or a landmark when you're looking at the slit lamp. Obviously, if it's larger than an average corneal diameter when you're looking at the slit lamp, you're worried that the ICL is oversized, and when it's oversized, it's going to crowd that angle. So I'm not sure, was there an attempt made, or was there a documentation of the actual vault on either side?
Yeah, I mean, so far all we have is the UBM here, and like you said, the penetration down to the lens is not great.
Yeah.
And I guess that's the question of how exactly to document this setting. I have to say that the iCube UBM, you know, does have some limitations sometimes, and we could consider doing, for instance, a Sonomed HD, which may give us a little bit better penetration, or some of the new anterior segment OCTs.
Yeah, I mean, so
Yogi, can you just tell us which of these images is which eye, because they are quite different looking. Some are deeper than others, and I can't see OD and OS on them.
Sorry, yeah, I didn't label them out clearly here. So the left side of your screen is OD, and the right side of your screen is OS.
Yeah, the top and the bottom. Top looks more open than the bottom.
Yes, again, the horizontal and the vertical axial. The vertical axial is on top and the horizontal axial is on the bottom.
Well, if you compare the vaults, looking at the UBM, it's less than 1 corneal thickness on the right eye, and actually the left eye is even lower. To me, from what I can see on the imaging, it looks to be about a quarter of the corneal thickness. So the angle could have been crowded before, and now just that slight vault has started to crowd the angle more. What I've seen with the ICLs is you get into trouble when the vault is so high that the pupil doesn't respond normally, and they often have a partially dilated pupil, and that's a sign that the ICL is oversized. But if I just looked at the vault, I'd say this is pretty good. In fact, the right is worse than the left.
Yeah, I agree. It's Ike here. I agree with Paul and David's comments and Yogi. Nice presentation so far. We often talk about the vault.
Yogi, just go to the angle slices too for Ike, just so we can try to identify the scleral spur while he's talking.
Sure.
The clock hour, the clock hour for the UBM. I think it's later on.
I don't have them. I have them hidden as a slide there, but I can pull those up here if that makes things easier.
Sorry, Ike, go ahead.
And I think Matt was alluding to what I think he knew I was going to get to, which I think David talked about it quite well. The manufacturer's recommendations are, depending on the hyperopic or myopic correction, is essentially 2.75 to 3 millimeters in AC depth. And just make sure we talk about AC depth as being, from the epithelium to the anterior capsule. We often get confused about, endothelium to the anterior capsule versus epithelium. That's always confuses all of us. But that just talks about the central AC depth. And I completely agree. These vaults don't look excessive. The best way to examine vaults still, I believe, are clinical examination using your slit lamp and assessing the corneal thickness. And as Paul said, the goal is to get it to about 1 corneal thickness. And they look like they're pretty well within that margin on the UBM, at least, as David mentioned. However, one thing we don't talk about, and the manufacturer perhaps needs to do more on this, is the angle insertion or the iris insertion. And so we can get eyes that have a fairly deep AC depth, but yet have a very crowded anterior chamber angle because of a high iris insertion. This can, for example, be a plateau-like configuration. It can be an eye that has relative anterior chamber, if you want to call it microphthalmus. And we know even though these are highly myopic eyes, they often have a relatively shorter anterior segment peripherally. So the angle examination is probably the key here. And I think your anterior segment OCT, it is kind of not so easy to look at the spur, but it does appear that there's somewhat of an anterior iris insertion. The other things to look for, of course, is that, is this pupil block? No, there's no iris Bombay, not an excessive vault. So really this looks like a peripheral angle issue that has been exacerbated by the presence of a foreign body in the sulcus. And has led probably to some angle crowding, anteriorization of the scleral spur and elevated IOP.
Is this image on the left, is that actually the patient, or is this just an example?
This is just a stock photo, just showing some angle, just some landmarks in the angle.
Yeah, because here, and the ones on the right-hand side, the vault looks higher. It looks like about 1.5 corneal thicknesses. And so, I think it's probably excessive. I don't know if this is the right eye or the left eye.
We have the right eye on top and the left eye on the bottom.
Yeah, so it's similar to what the UBM showed, where the vault was higher on the right eye, even though the pressure was less problematic on the right eye. And here his angle looks pretty open to me.
Mm-hmm.
And there was no pigment on the lens or anything like that that could suggest chafing and causing, some irritation of the back surface of the iris.
No, they were quite clear, surprisingly.
Okay, why don't you go ahead there, Yogi? I don't know if you could show those clock hour.
Yeah, would you like me to show them at the end? Because I can just open up I have some slides hidden that have them there, or I can show them right now, whatever you'd like.
Okay. Yeah, let's say bottom line is some of the clock hours are much more suggestive that angle closure than what we saw in the anterior segment OCT. But anyway, so why don't you just pull up the differential that's kind of, on our mind at this point. I think it's already been alluded to a little bit. This could just be completely not related at all. I think our gonioscopy exam makes us think that this is not an open angle phenomenon, that there potentially is at least some angle closure component. We talked a little bit about UGG, Schwartz syndrome, I think can always be in our mind. This patient did not have a vitrectomy, but has had two retinal detachments. And then we talked already about this angle closure, and you wonder, I think we've pretty much ruled out uveal effusion based on our imaging, and malignant glaucoma would be a incredibly rare presentation, I would think, in a high myope and a male, but possibly something to think about.
Perfect. Thank you, Dr. Schlenker. Excellent. So do we have time to put up a poll, or shall I just keep moving, chugging along there?
Why don't we go ahead? Why don't we keep on going?
Perfect. Okay, so let's briefly review some of the testing that we had. Again, the OCT and the visual field mainly that we wanted to chat about. I wanted to just spend a little bit of time on the baseline image here, the baseline OCT taken in 2014. Now, most people would think, in a myopic patient, an OCT acquisition is terrible, we're not going to use it. But actually in this patient, what's interesting is his RNFL, although is less in both eyes, appears symmetric in both eyes. And then, we obviously look at the metrics up at the top to make sure that the scan quality was good. But mostly in Toronto, I find that we look a lot at the numbers here, the RNFL thickness, and this can kind of lead us a little awry. I think one of the things, having spent some time with Dr. Schlenker, the main things we really want to look at is the circular tomogram, make sure the acquisition's good, and then looking at the heat map of the RNFL, and then looking furthermore at the T-SNP map after you've correlated that the tomogram is good and the heat map. Again, some people would say that the acquisition here, there's a large error that wasn't picked up, but thankfully it's outside of the ring of calculation there. So it shouldn't really affect our overall RNFL calculation. And so this actually does serve as a very good baseline. And so one of the things I'd like to briefly mention here is one of the largest changes we have between 2020 and 2014 is there's a lot of change in the heat map. There appears to be some RNFL loss superiorly and inferiorly. And when we correlate that over to the T-SNP map, again, looking specifically at the left eye, we do see there were a little bit of peaks here in 2014 that have now been muted to values in 2020. And it's the same thing in the inferior nasal to inferior RNFL. Some peaks kind of up here in the green area that have now been lost here inferiorly. So again, the T-SNP map, you can have patients that have, they may have some red disease or even patients that have floor effect. Most important thing to watch is the peaks and valleys that are occurring and seeing in any subsequent RNFLs or OCTs if there's those, muting of those peaks or those peaks turn into valleys, because you can get subtle changes there that might suggest progression. Looking very briefly at his visual fields, his right eye, quite unremarkable between the 6 years, between the 1 year, we weren't able to get a visual field from 2014, but comparison to the year prior, right looks okay. In the left, again, a little bit of reliability issues in both tests, and we are comparing a 24-2C to a 24-2. So again, we can't really comment too much on progression, but I just wanted to point out that there appears to be some changes inferiorly and superiorly compared to the year prior. So some people would ask, well, what about the macula? He had 2 retinal detachments. Could this be still, retinal in nature? And so, we look between the 5-line rasters between since 2013 and 2020, they appear to be relatively stable. To the keen eye here, some may notice that there's a little bit of thinning overall in the macula, the left macula compared to 2013. And again, comparing the thickness map between the 2 years, so this is the macular thickness, there does appear to be some changes. However, if you look more at the absolute values, the changes aren't that much, and they may be taking into account the actual GCC loss or the ganglion cell loss that we're seeing here. And so that may be playing a factor in the overall macular thickness. Now, again, most people would say, well, previous retinal detachments can cause ganglion cell analysis or ganglion cell loss, and they're not wrong. There are studies out there that suggest even out to 2 and 3 years, you do get ganglion cell loss with retinal detachments. However, the majority of these patients in the studies all had some form of intraocular retinal detachment repair, whether that be a vitrectomy, scleral buccal vit, or even silicone oil, which our patient didn't really have for the most part. So I think maybe we'll go past this poll here. Again, the thought was, is the RNFL thinning we're seeing retinal glaucomatous in nature? Just seeing if people's thoughts still were on retina or if it was, a little bit more glaucoma.
Yeah, I think I'll just pause here. I think we've all seen patients who have profound RNFL thinning and ganglion cell loss in the setting of previous retinal detachments and also other retinal causes such as arterial vein occlusions. Here you can see kind of, where Yogi's headed. It seems like, and I'd be happy for a retina specialist to comment, it seems like the outer retina actually looks quite good in this patient. There's a selective loss in the RNFL and GCC, which is usually more in keeping with a glaucomatous picture, as opposed to, say, a MAC-off retinal detachment where we also have outer retinal involvement. So we have disruption of the photoreceptors and the ISOS junction and such. I don't know if anyone wants to comment. I didn't see a lot of retina specialists in, but
Matt, we do have Peter, Curtis, and Kenning here. I just promoted them if either are available.
Yeah, Peter or Ken, any comments here on whether you feel like this patient obviously has an eye pressure issue? Are we overcalling this quote unquote progression?
Don't ask a retinal surgeon about glaucoma progression. That's dangerous.
I think I got promoted to a panelist. I would say, sorry, I got disconnected for a minute, but I would say that, in the setting of retinal detachments, we're more focused on the outer retina than the inner retina, and the changes that we see are usually in the ellipsoid zone or in the integrity of the outer retina. So seems to me that this is likely glaucomatous in origin, but what do I know?
Okay, thank you.
So
I guess the question, Yogi, is does it really matter at this point? Is it more of an academic question, or is it clinically going to make a difference to your management?
That's a good question. I think that's where we weren't, when we chat a little bit about the management, I think that was going to be one of the questions was if this was retinal in nature, maybe if the thought it was still retinal in nature, he may, the suggestion maybe he could keep his ICLs in, because we don't believe that there appears to be a glaucoma, a glaucoma play in this. But I think we've kind of alluded to in the presentation as we've been going on that it appears though there does appear to be more of a glaucoma aspect in this, and potentially a chronic angle closure picture that we're seeing. So possibly, I think the retinal play is lowering down or getting a little bit less here.
Yeah, I just think that a young patient who I assume has fairly normal corneal thickness with pressures that are in the low to mid 20s, it's just not a long-term situation for someone, that we want to keep them in, whether it's related to the ICLs or not.
Mm-hmm. Yeah, thanks, Dr. Ahmed, for that. Agreed, yeah. So I just, again, wanted to briefly go over what the literature said regarding diagnosis and management of these patients. Again, a good gonioscopic exam is obviously gold standard to determine what's going on with these patients. But now with newer technologies that we have available to us, UBM and anterior segment OCT are playing a very large role in determining the placement of these ICLs, the diagnosis of any sort of angle closure or chronic angle closure. And as well as measurements pre and post-op, as Dr. Sangera alluded to as well. They play a very important part in managing these patients, and including pre-op measurements and post-op, in ensuring that basically these lenses are placed as well. Now, 3-year FDA data, the FDA study that was released quite a while ago, actually suggested that these lenses are quite safe, and there was only about a 0.4% explantation rate of these lenses. Only about 1 or 2 patients had them removed. And interestingly enough, concurrently at that time, cataract surgery was done in these patients. I suspect mainly because in the removal of these lenses, they probably potentially could ding the natural lens and actually cause a cataract. So again, very few cases out in the literature right now as to removal, whether they're being, whether truly their safety profile is quite good and they're not being explanted, or they're just being underreported. It's difficult to say, but I think one of the things we were going to chat about as well is the management or removal of these lenses. We've got a lot of great experts here that can chat about it here, but what we're finding is that a lot of these patients had them explanted and had concurrent cataract surgery done at the same time. So I just want to briefly recap. We've got a 32-year-old gentleman who's had 2 previous retinal detachments and 2 previous strabismus surgeries all in the left eye. He had some ICLs placed in 2016, was diagnosed with glaucoma, and now managed on 2 and 3 classes of medications. Progression on OCT was there, and there was likely some progression on the visual field. The exam of the anterior segment imaging is quite suggestive of chronic angle closure, secondary anterior push from these ICLs. So my question to the audience is, what would you do next? Would you continue topical treatment and frequent follow-ups? Or would we just watchfully wait this gentleman? Would we, do some more laser peripheral iridotomies or surgical iridectomy? Some of the literature previously said that, if you enlarge the iridotomies, it would help with flow. And, if the picture was angle closure, this would maybe remedy the situation. Would you remove the ICLs and do a phaco, plus minus phaco at the time, or would you jump to incisional glaucoma management, whether that be trabecular bypass MIGS versus a filtering surgery?
So I think, why don't you stay on that slide and open up to the audience? Any thoughts? I think the last time his pressure actually had come down to 14 on his 3 classes, at least in clinic. You saw his eye care home that shows that there's a fair amount of fluctuation, but not acute IOP spike secondary to acute angle closure episodes necessarily. Really interested to hear what other people would do in this setting. And he really likes his ICLs, and he really values his reading vision too, by the way, if you were to go ahead with phaco.
Matt, do you want me to run the poll for this?
Sure, let's run the, sure, I can turn it on. I got it. Okay, so it looks like it's a tight race here. We got 43% want to remove the ICLs plus minus phaco, and then we have 27% want to observe them at this, now on topical therapy. 23% did want to at least try enlarging the iridotomy, and 7% going ahead for surgery. Keeping in mind, again, this is a very scarred conjunctiva. He's had a scleral buckle, and he's had 2 strabismus surgeries and a removal of the scleral buckle. Any comments? Ike, you want to comment?
Yeah, I think, anytime you have someone with an elevated pressure, and it sounds like historically there was no documented elevated pressure prior to the ICLs, is that correct?
Correct, as far as we know.
Yeah, so there's the history part of it. There's the angle configuration and the anatomy, which I agree. The imaging is probably a little bit variable. The vol question, I think, is still there. I agree. When I look at the OCT now, actually, that you showed after, it does make us wonder. And possibly with a bit of a crowded angle, I think you got to basically, deal with the angle issue right now. Remember that, differentiating angle closure from open angle glaucoma is important, but we also have a concept of just a crowded angle. When you have a rotation of the iris, you have rotation of the scleral spur, which reduces the effective filtration area of the trabecular meshwork, and that itself can cause TM dysfunction in the absence of having an obvious closure. So I think just relieving the angle, letting the iris fall back, would likely have a chance of improving trabecular function. This guy's a young gentleman. He's got risk factors potentially for having an open angle mechanism independent of the ICL, but I think that one would have to address the first issue. And I will say again, we have a long track record of ICLs, as Yogi said, and I think it's been quite good. It's not common to see these issues. They're in higher risk individuals as this individual is, and I assume that there probably was, if we gonioed him preoperatively, I would assume that perhaps there may have been something there to perhaps alert us that this patient may be at risk. I don't think it's a good idea to put ICLs, for example, in patients who have, near quote unquote narrow angles or Schaefer, grade 2 or less, even though the AC depth may be of normal proportion. So I guess we don't know that answer, but that would be my answer. And I think there's no indication for phaco here. It sounds like, so I would avoid that, certainly with his risk factors and presbyopia and everything else. Removing an ICL is not actually that difficult. I'm sure others who have done this would probably agree. Fairly atraumatic and can be done, in short order. So that's probably what I would be looking at myself.
Thank you. Any other comments from anyone before we move on?
Why not try and just what my concern is that you're going to remove the lens, and then it's still going to be problematic in terms of glaucoma pressure control. So maybe try one eye first and see what happens.
Yeah, one eye is going to leave him quite anisotropic, and that's overall. He's really not keen on having these removed. He really enjoys them. He feels like he's not sure he can continue his profession really without them. He really does want to keep them in. So it's a tough call. Yogi, why don't you stop your share and get Ahmed, and if anyone has any comments while we're switching over to the other presentation, that'd be helpful.
I mean, the one thing you consider, of course, is whether you would consider adding like an angle procedure with the ICL explantation if we went that route, just to deal with potentially any underlying open angle mechanism. As you know, in juvenile glaucoma, goniotomies actually perform fairly well. And that's something maybe we would consider to do a limited goniotomy plus or minus trabecular meshworks bypass stent, safe, and potentially could address an underlying open angle mechanism to deal with that potential that's underlying as well. And doing one at a time, I would just do one at a time. And I would just tell the patient that I'd want to see how the patient responded and see how the pressure responded. And I agree. I think, unfortunately, it's going to be a bit of a rocky road, perhaps. And I understand he doesn't want to have it removed. I gave my opinion. I think that this is potentially, he's got a glaucoma issue, whether the ICL is related or not. I don't think the ICL is helping here.
Yeah, I think I agree with that. If you want to really be out there, one thing you could consider doing would be exchanging it for a iris-supported lens like the Artisan or Artiflex, and that way you're going to open up the angle and still maintain his refractive correction. Me neither.
Matt, the only other comment I'd add to this, in terms of the retinal thinning, I know he didn't have a tamponade with oil or gas, except for the pneumatic for a short period of time. I do wonder, in the history, it said he had a MAC-on RD, but I actually know this gentleman, and I saw him when he initially presented, and he actually was a MAC-off. And I don't know if that would have impacted anything, but based on Peter's comments, I don't think so.
Yeah, well, thank you. Actually, and we weren't exactly sure on that first retinal attachment. It was a while ago, as you said. And yeah, it's the outer retina is just not in keeping with what I see with some patients who've had serious retinal issues. I mean, it actually looks pretty good. I mean, I'm surprised it's macula off. And yeah, I guess we heard what Peter said, and I'd be interested in more comments, but I just think the outer retina looks quite good.
Yeah, for sure he was MAC off.
I have other patients, I brought this up earlier where, I don't know if an IOP target has to be 12 for a patient who has secondary Arnefelt thinning from a serious retinal issue, from a vein occlusion or a MAC-off RD where the retina is completely obliterated. I just don't know I think it's helpful to have a lower eye pressure, but I'm not as aggressive as, say, someone who I really feel like this has been a pressure-mediated issue. Okay, well, thank you for those comments. Not an easy situation. We'll get Ahmed to go. We're going to change topics quite a bit here, actually. So now think of yourself on call, up in Barrie or wherever else, and then this patient comes to see you.
Good morning. I'm Ahmed Elmir, one of the PGY3 residents, and I'll be presenting a case today with Dr. Schlenker. And this is the QR code for the residents to scan and for evaluation forms too. So our case is about a 78 years old male who was referred with an IUP of 29 on 5 classes of medications. And he reports from history that he had uncontrolled eye pressure since his cataract surgery 10 months ago. And he was on Maxidex when we saw him for 3 months. He was on glaucoma drops in the right eye for 1.5 years and 5 years in the left eye. There was a questionable history of maybe ALT in 2013, and he has a positive family history of glaucoma. So this is his eye actually, and the exam of the right eye was unremarkable except for an inflamed conj too, as the left eye shows here. The vision is 20/40 plus, and his pupil was small because he was on pylo, and there was a positive reverse RAPD. Again, the pressure was 29 when we saw him, and the conj was really inflamed, hot, and injected. His cornea had PEs, AC was deep with rare cell on Maxidex BID, and he had pseudo-X, no TIDs, and he was pseudo-phakic. The angles were open, and he had 1+ pigment, and the cup to disc was 0.8. OCT, so remarkable asymmetry. You can see that even from the heat map. Yes, less signal strength on the left eye, probably because of illumination. He was on pylo, small pupil, but that's pretty remarkable. You can see it here, and even on the T-slit, you can see the asymmetry in the superior and inferior significant RNFL loss, and also the ganglion cell analysis shows that too. However, I mean, in this context, with high IOP on 5 medications and probably pseudo-X too, we could attribute that to glaucoma, but if we just look at that OCT in different contexts, we should always think about other causes such as non-glaucomatous optic neuropathy and maybe some retina too, some maculopathy. So here looking at the cube, we do see asymmetry, which again is probably attributed to the ganglion cell loss, because if there was a maculopathy, the OCT will be more white up here and then on the cube. So the fields also correlate well. So there's severe depressed left visual field. So he has severe glaucoma with an island of preserved vision here. So in summary, he's a 78 years old male with an IOP of 29 on 5 classes. AC is quiet, but on Maxidex for 3 months. Has advanced left pseudoexfoliation glaucoma and possible uveitic component plus minus steroid response. So at this point, we tried to remove any reversible causes of high IUP. So we stopped Maxidex, tapered it down, then stopped it, started on Diamox, and asked him to follow up locally in a week, and then with us in a month with UBM, given that he had high pressures after cataract surgery, and he was on Maxidex too for that. So on his 1-month follow-up, the pressure was lower, 21, but still on 5 classes and Diamox. It was off Maxidex then, and the EC was quiet. And those are the UBMs. We can see the IOL was in the back. So on summary again, 78, the pressure now is 21 on 5 classes of medications with Diamox. AC is quiet off Maxidex. UBM showed IOL in the bag. So he has left advanced pseudo-X glaucoma with maybe uveitic component. He was quiet though here, and steroid response. So if we can put on the whole question. So what would be the next step? Are we going to observe SLT, trabecular bypass mix, subconj mix, trab, or tube?
Yeah, so Ike has a good question here, why this patient was on steroids for so long. And he also had another question. The only risk factor he had for uveitis glaucoma hyphaeus syndrome was the fact that he has pseudoexfoliation. We didn't see any donesis in the exam. There was more pigmentation on the trabecular meshwork on the left side, though he also had much more pseudoexfoliation on the left side. The inflammation is a little bit of a question mark. We unfortunately, he wasn't followed very closely there, and it's not clear whether the Maxidex was a mistake to leave him on for so long, or whether they're treating his profound surface disease, or whether he had an active uveitis after his cataract surgery. Though we will say that after washing him out of the steroids, he did not have ongoing intraocular inflammation, but still had the profound blepharitis and ocular surface disease in both eyes. Okay, so we can see here from our next step is 33% of people were electing for a tube shunt, which is what we did. Go ahead, Ahmed.
So yeah, we elected to go with a Baerveldt tube. And that's the video of the surgery. I'm just going to talk about Baerveldt briefly. So it's an unvalved tube. So we usually ligate the tube, and this ligature that we're seeing here is going to dissolve usually in 6 weeks. And meanwhile, we talk to the patient and we expect high pressure. So likely patient will be on drops and even Diamox if needed. And here we're also doing fenestration distal to where the ligature is, to just as a temporizing measure to reduce the IOP throughout the first 6 weeks period. And also there's the ripcord that we can see in the lumen, that also something that we can manipulate, and depending on the pressure, if it's not controlled with medications, we can pull this out because it's actually just in the conj. And so that's the IOP curve post-op. So he had acceptable pressure. That was post-op day 1, and then started going up. So we started adding the drops, which again, expected in a Baerveldt case. Then added COSOP when it went to the low 30s. And here, just before, like it was 4.5, maybe just less than 5 weeks, he came in with hypotony pressure of 5. So we just mentioned that we expect the pressure to drop in Baerveldt 6 weeks later. So what is the reason of him being hypotenuse 4.5 weeks post-op? And
why don't we pause here? I think I saw Sam on here. Why don't we ask Sam what his differential is for hypotony 4.5 weeks out of a Baerveldt? We have Sam? Sorry, maybe we had Brian.
After a Baerveldt, you could have, I guess you could have like, not sure if you'd have peritubular flow, or you haven't, like the ligation isn't open, or sorry, the ligature is actually open. It's not both sides tight. So you have a lot of tube flow still. You have, I guess you could have some issue with like ciliary body shutdown post surgery, but that's pretty late for that, being 4 to 5 weeks post. So if there's still high flow through the Baerveldt, or it hasn't like encapsulated well, you're just getting a lot of flow past.
Okay, thank you. Yeah, I mean, I think, I use a 7.0 Vicryl, which is what most people use. Some people use different sizes. A 7.0 Vicryl usually dissolves at about the 6-week mark, and that gives the capsule sufficient time to develop so that you're not going to get hypotony. But this is fairly early in my experience, probably the earliest I've ever had a potentially dissolving. So I agree, you want to think about other things, like you maybe had some type of dehiscence of your conj that's allowing a leak, or ciliary body. We had that kind of query uveitic history as well. Why don't you go ahead, Ahmed?
Yeah. So,
and of course, anytime your pressure is low, you got to look for retinal detachment as well.
So yeah, so exam showed that the conj closure is intact, sidel negative, AC was shallow, and he had choroidals, the retina was flat, so we ruled out other causes. So we attributed that to overfiltration and early ligature dissolving. So we did an AC fill with Provisk, and an hour later the pressure was 13, so he underwent a second fill on the same day, and the pressure was 28 then. So we stopped his IUP lowering drops and started him on atropine. So we can see here, so that's post AC filled IUPs on follow-up. It was like in the mid-teens. It was 14 and then 16 on 2 days follow-up too. And then a day later, he comes in, and this is an ophtho resident getting this call. So ER saying is, hey, is this ophtho? Ophtho, yes. How can I help you? And this was what the ER physician said. He's like, I got a 78 male who had glaucoma surgery 5.5 weeks ago. He had low pressures 3 days ago and apparently got an injection. He saw his doctor yesterday. Everything was fine, but he comes in with progressively worsening eye pain and blurry vision throughout the day. The tonopin reads as error, and it's possibly a high pressure issue.
Okay, why don't we stop here? I'm trying to unmute Ellie with no success here. Oh, here we go. So you get this call from the emergency department, and just again to set the stage. So the working diagnosis was overfiltration. He got an injection of this, in fact, 2 injections of viscoelastic in 1 day. And then he was followed closely after that. He was seen the day prior. His pressure was 16 with a formed anterior chamber and some choroidals. And then the next day you get this call. What are some of the things on your mind?
So if he had an injection of viscoelastic, obviously worry that maybe there's too much viscoelastic in there, so it was overfilled and the pressure was gradually increasing over time. And if Ahmed mentioned that his pressure was 16 and then you did a second injection, so possibly just a little bit too much viscoelastic in the AC that hasn't cleared yet. But like you mentioned, if there are choroidals there and there's the pressure was low previously, it's possible that the pressure dropped and then he had a suprachoroidal hemorrhage that may have shot the pressure up high. That's probably the 2 things I would be thinking about if I got this call.
Okay, good. Yeah, I think those should be the things on your mind. Provisk was injected. That's usually our protocol. Provisk usually doesn't last this long, but I agree. You still have to keep in mind Provisk actually doesn't clear very well from slits. Though here we were thinking that the ligature is already dissolved. Helon, especially if you use Helon 5, that can last a lot longer. So I agree that should be on your mind. But I also agree that we need to be worried about a suprachoroidal hemorrhage here. We'll point out it was very clear from the patient that the pain was kind of insidious onset. It wasn't one of these, they coughed or they bent over to lift something. Which is usually more characteristic for a suprachoroidal hemorrhage. It was just kind of this, and this is he's a farmer from up north. He's a stoic guy. He's clearly not one that complains. I said he's been walking around with this very severe blepharitis for I don't know, how long. And he just said it just kind of gradually came on through the day to the extent, to the point where he was almost writhing in pain. It was quite severe. Okay, so Amrit's asking a good question. I think let's get Taylor on because Taylor had the fortune of seeing this patient in the middle of the night after he was sent down from a northern emergency department. Can we get Taylor on and Taylor can just say what he found? Amrit's asking about the exam.
Taylor should be on now.
Can anyone hear me? Sorry, am I coming through? Hello? Can anyone hear me?
Maybe Ahmed, why don't you go ahead unless Taylor's,
Sure.
No, we can't hear you, Taylor.
Yeah, so patient was extremely uncomfortable and he already received Diamox at his local emergency department and topical therapy. And that was his exam. So vision was hand motion, pupils radiality was on atropine, and pressure was 61. when assessed by Taylor, and he did have edema, shallow AC, and the tube seems like in place, and the valve was covered with conj. So what's the differential diagnosis at this point?
You go ahead for sake of time.
So we thought about he's overfiltration, and this is just an artificially elevated IOP with shallow chambers. And if is there a posterior pushing mechanism that explains the possible high pressure and the shallow chamber mostly, such as malignant glaucoma or suprachoroidal hemorrhage, which Ellie mentioned. And so this was the B scan, and it's pretty clear. So there is no reason for other, like there's no suprachoroidal hemorrhage or anything else that can explain the posterior pushing mechanism. So the diagnosis was then made that it was a malignant glaucoma. So it was managed then in the emerge with, again, topical therapy, pain control, given IV Diamox, 500 milligrams, and mannitol, infused over 45 minutes. He was reassessed 6 hours later. The IUP was 16, and the EC was deep, even the AC. So the plan going forward was to continue the Diamox and on max topical therapy and on atropine and Predfort, and to follow up in the morning. And then that's when he saw Dr. Schlenker again. So the pressure was 61, 16 here just a few hours later. And then by the time he saw Dr. Schlenker, the AC was still deep, and the pressure since remained actually around 7 for a few visits until 6.5 weeks away from being post-op. Malignant glaucoma is diagnosed of exclusion, and this patient's risk factor to develop malignant glaucoma was shallow AC and pseudo-X. And it's really important to rule out other posterior pushing etiologies by doing a B scan overnight, and if UBM is available would be helpful. And shallow AC shallow AC can cause artificially high IOP with Goldman tonometry.
Yeah, so I just want to pause here for a second, and definitely interested in any comments. Amandeep, if you see anyone raise their hand, feel free to promote them to a panelist. I think this case was a little bit atypical in a few regards. One is we saw this patient on a Friday, and he had choroidals on the Friday, and he had a formed anterior chamber. And then Saturday morning is when he right away started to get this pain. So things happened really quickly, where, as you can see, by the middle of Saturday night, his choroidals were completely gone. The chamber, Taylor's had some troubles with his audio. When he called me in the middle of the night on the Saturday, it wasn't completely shallow. He was telling me how the iris was kind of empty, the tube a little bit. It wasn't completely shallow. I, of course, was worried about a suprachoroidal hemorrhage, and Taylor diligently went, he went and got that B scan. And I was a little bit surprised to see a malignant glaucoma happen so fast like this. He did have pseudoexfoliation, which again is kind of a soft risk factor. Often when patients come in and they're pseudophakic, we don't know what their axial length was before. And so, of course, I'm thinking in my mind, shoot, this was a high hyperope, that we should have been maybe more aggressive, making sure that his chamber was formed with this kind of early ligature dissolving. We ended up doing an axial length after the fact, and it was 24. So it's not common to be getting a malignant glaucoma picture, A, in a male, and B, with an axial length of 24. We're trying to think of other possibilities of what could have led to this. Theoretically, iris could have incarcerated into his tube shunt. It would be unlikely for the tube to be shallow, or for the chamber to be shallow at that point, unless it was just caught at that point where it was shallow and the tube blocked off, and then it was going to be deepening as the pressure came up. But I think the most likely picture here, I'm interested in anyone's thoughts, that he had malignant glaucoma, and thankfully, Taylor saw the patient, so this all happened in the middle of the night on Saturday. He saw the patient in the morning, and he called me, he said, the chamber looks really deep, and I was surprised to get such a quick response. And then I saw the patient with Taylor at about 4 o'clock on the Sunday, and yeah, the chamber was completely deep.
Matt, would you expect to have such a quick resolution of that dramatic picture like that medically?
No. I mean, I exactly. I don't expect it to happen that quickly. That's why I wanted to see it myself, because it doesn't completely seem to add up as a picture. Something else to point out too, in these settings where the iris is quite close to the cornea, you really can't rely on our standard IOP measurements. You really got to get your finger on the eye, and thankfully you're going to have the other eye as a control. And that's where, Taylor will tell you in the middle of the night, he felt like that eye was completely rock hard, that the pressure really was high. And you don't have to have a really high eye pressure to diagnose malignant glaucoma, especially sometimes the cornea can be swollen as well in these settings. So the eye pressure is hard to use the exact number. You gotta do digital palpation and look at kind of the whole picture. But I agree. I mean, it was fast. It was fast how things happened. But I also don't have a better explanation for what happened. I'm just happy that we were able to resolve. And really, the mannitol seemed to do the trick quite quickly.
Matt, is it possible that this seemed to be provoked by the OVD injections, right? Is that correct?
Well, it was Provisk, and it was 3 days before. And we saw him, and the pressure was 16 on the Friday.
Yeah, I mean, the only thing I add to that is that, so it's an inadvertent injection into the vitreous posteriorly, which would be rare and unusual and not necessarily delayed, as you said. Also an anterior, annular effusion. I don't know if you had a UBM or anterior OCT could do that, as well as part of the differential. And then, someone with loose zonules, I mean, the IOL could just be pushed forward and give you very shallow AC, especially in pseudo-X in that sense. But I expect you'd have, a fairly obvious dislocated IOL at that point.
Yeah, I think because of the pseudo-X, you could get OVD go behind the zonules. I mean, I do think that's a possibility. It just the chronicity of it does not seem to make sense to me for that as a potential mechanism.
I mean, the thing that happens is, of course, these patients have hypotony, they have some inflammation, they have some supraciliary fluid, they don't secrete. And then you get the pressure up with the injection, and a couple of days later, all of a sudden they start secreting, right? They start producing normal aqueous flow. So they go from 0 to 2.5 microliters per minute. And then that combined now with everything else in the picture here can cause a sudden rise. So that could also explain a little bit about the sequence of events that you go from hypersecretion to normal aqueous secretion, and this led to the sequence of IOP elevation. That's another part of the picture. Of course, we're reaching a bit here, but that could explain some things as well.
Yeah, I mean, that's where in that setting, I would think that the chamber would be nice and deep, though there's a lot of things happening quickly in this eye. So I agree, it's hard to say for sure, what was what. But I have to say, I was pleasantly surprised when I saw the B scan. We've had lots of debate, the glaucoma community as well, whether you can have choroidals and malignant glaucoma at the same time. My sense is maybe there's a small window of minutes to hours where that could happen, but generally speaking, if you see choroidals, then you're not in a malignant glaucoma situation. And as you guys saw in the B scan, the B scan was completely clean despite less than 24 hours before us clinically seeing quite significant choroidals.
And usually with malignant, you see more choroidal thickening as well. Like you see a thickened retinal choroidal scleral thickness, and quick view didn't seem to be that expanded.
No, absolutely. And then again, the 24 millimeter eye, and Varma has a paper where I think there's 18 patients in the paper with malignant glaucoma, all of which are female. So it's not a clear picture. Muhammad just put a comment on the chat, to us panelists. He's saying, if we would have just done an OMED, we would have not necessarily had these problems. And I do agree that I think we're showing some of the problems that you can develop with a Baerveldt. And the reason sometimes we do a Baerveldt is because the literature, I think, is quite clear. And also my own clinical experience is you get a little bit better IOP control off medications. And this is a gentleman who's had a lot of trouble with medications. You guys saw the picture of his conjunctiva. going into the surgery at fairly advanced disease. But yeah, in hindsight, and we're actually still dealing with some of his issues here, you wonder about an Ahmed. The rural is a little bit of a factor as well, and sometimes swaying us towards an Ahmed valve.
And Matt, I think you'll agree, and you've just published 2 papers on PreserFlow as another option, which I think we see much better, smoother control in the early postoperative period.
Absolutely. I mean, Ahmed's and PreserFlow are our winners in terms of a smooth IOP course. It's still an open question with such bad conjunctiva, how well he would do with the PreserFlow. I do think we probably, my hypothesis is that a PreserFlow is going to be a little bit more durable than, say, a trabeculectomy in the setting of significant surface disease. But we know that one of the reasons we go to our tube shunts is that they do seem to be durable, and that's if we can get them through this difficult course, hopefully you can have reasonable IOP control in the long term.
So thank you very much, Matt, to you and your resident presenters. These cases really do illustrate the difficulty in managing unusual cases of glaucoma. So it was a great presentation. Thank you very much. Just a reminder to everyone that it's virtual AAO next week. So we're going to postpone our rounds to the following week when we'll return with, I believe it's Dr. Margolin in neuro-ophthalmology. Here is the QR code for those who missed it earlier for the evaluations. Tremendous job, everyone. Thank you again.
Thank you, everyone. Have a great day and have a great weekend.
Great job, guys. Bye.